So I want to just give a little overview of actually what gender affirming hormone looks like. So I'm not expecting that most of you as healthcare providers will actually provide hormone therapy, but some of you might be interested to become involved. I really would like to encourage people who are keen. There's a nice 6-hour training on the HIV Clinician Society website, it's a free training. You get a CPD points, etc. We've actually got one of our previous interns here who's become really interested in this program and has actually been joining us for the sessions and has done the training. So people who are keen to step into this space, there are training and mentoring available. But it is important if you've got transgender people that you see in your clinic or your CH or your hospital and they're asking about hormone treatment, that you can refer them to the appropriate place and tell them a little bit about what it's all about. So I'm going to just quickly go through the guideline. Basically, hormone therapy is what we use. It's very safe. It works very well. It's very essential for transgender people who have a very strong experience of dysphoria or is feeling that this is really something they need to add benefit to their affirmation journey. And the drugs we're using is literally the same as the contraceptive medicines that we have. So we're not using very complicated medicines, and the actual steps of treatment is extremely easy. The one big thing has changed, and I'll spend quite a bit of time on that, is that very informative that gender affirming healthcare, a bit similar that when you're providing care to somebody who wants a sterilization, a tubal ligation, or somebody who wants a vasectomy, or somebody who wants to go into contraception, this is an informed consent process. Your only role as a healthcare professional is to give enough information for the patient to make a decision. And then very important is we want to integrate care. So ideally, if you're seeing somebody, you're the same person who's doing their art or is doing their diabetic care or is doing their other care also needs to be providing the hormone therapy, ideally, so that we have integrated packages. Just a few little myths. So you don't need gender affirming healthcare to be trans or to validate being trans. There are many trans people who are very comfortable with just social transition. Some people are nervous about taking hormones for a variety of reasons. Being on hormones doesn't make you more trans, or not being on hormones doesn't make you less trans. It's just part of their own journey. Medical gender information is not a strict roadmap. This is how much you must take. This is how quickly things must happen. You have to go for surgery. It's very, very individual journey. And so forth. It's very much driven by what the patient needs. So some patients have got very strong dysphoria and how they experience their bodies, but actually you don't need to be dysphoric. You don't have to prove that you're mentally distressed and therefore need to go into hormone therapy. Very important, this is not a mental illness. You don't need to have psychotherapy. You don't need to be seen by a psychologist to go into hormones. Quite a lot of transgender people need support.
Sorry, Dr. Miller, you went silent there for a moment.
Hi, Dr. Miller. I think your microphone is muted. We can't hear you.
Apologies for that. Yes, unfortunately on Teams, I can't see my mute button. I have now found it again. I did hear you saying that. Can you hear me now?
Yes, we can hear you now. Thank you.
Okay. Thank you very much. I'm just putting my presentation back on. I assume, did you hear, can somebody just tell me where did I get to talking about dysphoria? I just need to know where I was when I went mute.
Yes, you did discuss this for you.
And did I talk about psychotherapy?
Yes.
Thank you. Perfect. So great. So yes, so we don't need to have, we need to have mental health support, but we don't need a psychiatrist to tell us that somebody is trans. And very important, there's no requirements that they have to have been socially transitioned for a certain period of time, or they must have shown and proven that they're serious about this. So the indications for gender affirming healthcare is very much just a desire. Somebody comes and says, I've thought, and usually I might say almost all the patients I've seen that ask for gender affirming hormone care therapy has been thinking about it for years. So usually by the time they actually get to a healthcare professional, they have been reading up extensively, they've been talking to people, they normally know more about it than you do. And that is the most important aspect. There definitely needs to be a persistent incongruence between their assigned and experienced gender. So yes, we do not particularly want somebody who's woken up this morning and thinks, oh, I want to try this out. So they need to have some experience that this is something they've thought about. They've had that experience for a period of time. And of course, they have to be able to make an informed decision and be able to give consent to treatment. So this is the table out of the guideline, and we're going to go through these in detail. So they're going to talk a lot about the discussion before your informed consent can happen, your baseline assessment you need to do. Then you're either going to use feminizing or masculinizing therapy, depending on your patient's needs, and then how we monitor those patients once they're on treatment. So the big thing that has shifted in gender affirming healthcare is that in the old model, where it was seen as a disorder, there was very much what we call the gatekeeping model. So you as the healthcare professional had to decide whether somebody now was trans enough to qualify to go on to treatment. And depending on what happened, you would carry the burden of the responsibility because you now have made the decision that this person should be going on to these treatments. We now work very much on an informed consent model. And this is not the Mickey Mouse consent that we do when we like just get somebody just sign down here. Informed consent means you as a healthcare professional needs to make sure that you've explained to the patient is what's going to happen. So the idea is that we are empowering the individual, we are upholding their autonomy, we're collaborating with the patient on that journey, and it's your duty to explain to the patient what's going to happen. And I find the most important thing in terms of this informed consent process is managing expectations. So what people think may or may not happen when they take hormones. So when you're giving somebody hormones, you're going onto a process of a change that the person very much would like to go through. And you need to make sure that they have considered all the implications of that. And so it's fine to that there's enough time for this process. And while we don't want people to make this decision out of a place of anxiety or fear, or they must not feel under any pressure or coercion in any way, so that they can really think they thought through all of these things before I'm going to make changes to my body. It's similar to getting a tattoo. So we very much respect the autonomy of the human beings, and this informed consent process is very much aligned with the HPCSA ethical guidelines, which talks about that your personal beliefs do not prejudice this patient's healthcare. So you might have your own ideas about what you think should or should not happen with transgender people. It's not your responsibility to make a decision for the patient. Your only responsibility is to give the patient information. It's also therefore not your responsibility in terms of those outcomes. The patient has to take responsibility for what happens for them. So if you are someone that from your culture or religion, you find it very difficult to come to terms with the gender diversity, that is part of your view of the world. And it's more about how do I make sure that I refer my patient to a gender affirming practitioner. What we cannot do is try and impose our own ideas in the person that's sitting in front of us. So in terms of informed consent, so there's a few things we're going to talk about, and when I talk about the different therapies, we'll cover some of that in detail. So I'm going to talk about the risks, benefits, and the reversibility in a moment when we talk about each of the different ones. Very important for patients is to understand how long the changes are going to take place. So when patients go onto hormones, they're going through puberty. If you think about puberty, puberty takes years. So even though you have a steady amount of hormones from the ages of 12, 13, 14 until 16, 17, actually the changes that happens in your body is a slow growing process that happens over time. And this needs to be explained to the patient. Just like puberty, it's extremely individual what those changes are going to look like and how long those changes are going to take. So you can't actually tell the patient this is how it's going to be. It's going to be a journey. And that's where the managing of expectations is very important. They need to know roughly what they can or cannot expect. And most of the disappointment or frustration with hormone therapy is when the patient has had an idea of what they think they would want the hormones to do their body, and it ends up not being as per their expectations. The most important conversation, the one that needs the most time and needs the most careful consideration, is reproductive options. So both feminizing and masculinizing treatment can reduce fertility. It's not guaranteed, but there are a high chance that after several years on hormone therapy, the fertility might not come back if you stop the treatment. And so that needs to be thought of ahead of time. What if you one day decide to have a child? So in the private sector, there's cryopreservation options, both for sperm and oocytes, expensive. So unfortunately, it's really only for the very, very rich. But it's not about saying, what if you ever want to have children? It's more about having your own genetically determined children. So it's having a conversation around what they think about adoption, how important it will be to have a genetic child of their own. And that needs you need to go and sleep on this, you need to think about this, because this is the one thing that could potentially, it's difficult to imagine where your life's going to be in 10 or 20 years' time. There needs to be enough time for discussion and reflection. And as I've said, most of these patients have done a lot of reading. So they'll usually come with lots of questions. And that's why you do need somebody with a little bit of an expert in the field to be able to discuss all of these things. And there are obviously side effects, and some of the effects are obviously irreversible. And that's where your responsibility comes from an informed consent point of view. So in terms of our assessment, you're going to take medical history, and you can think about this the same way you would think about when you're putting somebody on contraception, right? So if you're going to use core hormones, or if you're going to give somebody hormone replacement therapy that's postmenopausal, and we want to obviously look around things like cardiovascular disease, VTEs, especially hormone-related malignancies, your dyslipidemia, your metabolic organs. So those typical risks that we have with our contraceptions as well. Same with family history, if they are family-related malignancies or VTEs. None of these are really contraindications for similar than hormone therapy. It's just things to be aware of. You obviously want to know what surgery there's been in the past. Very important, we do not need to do a full physical examination of all of this, similar to contraception. If the patient is completely well, has got no other complaints, you only need to examine what is relevant to that patient's consultation. This is from the HIV Clinician Society. There's certain baseline bloods that we will do, and they've got actually suggested panels if you're in private sector versus if you are in a resource-constrained setting. Please remember also for your HIV and syphilis screening, obviously. And if somebody's starting masculinizing therapy, if they're going to start on testosterone, to have a pregnancy test. So let's just look at feminizing, gender-affirming healthcare. So this is somebody who wants more feminine aspects, and you want to suppress the androgens. We want to ideally use bioidentical hormones. So in our setting, that would be estrogen. I'll show you in a minute. Parenteral is best because it doesn't go through the first pass effect through the liver. But in the public sector, we only have the oral hormones available. But in private sector, they would often use the subcutaneous estradiol. If they are on the oral gender-affirming hormones, then actually, because of the first pass effect through the liver, there's not quite enough estrogen that ends up in the body to completely suppress the testosterone. So you also need to give an anti-androgen to actually suppress that as well. And we generally don't use progesterone. Progesterone doesn't actually feminize as such. There's some fancy stuff in private. So this is the important slide, or the important things you need to discuss with your patients. So this is the kind, and you can see here the amount of time it's going to take and the time it might take to get maximum effect of that particular change. And you will notice that most of these things are reversible. So even in all our discussions about things that's going to happen, when they stop the hormones, most things are going to actually go back to the way it used to be. So body fat distribution can take 2 to 3 years to get that more feminine figure. There's some decreased muscle mass and strength, skin softening. Change in sexual desire is very important. So quite often in people assigned male at birth, they might have a predominant testosterone, and therefore their predominant way of attraction might be through sexual desire. Obviously, if you're going to suppress the testosterone, sexual desire might decrease, but what happens is quite often the type of desire changes. So there's another type of desire, which we won't cover here, which has got to do with sensual desire, so attracted to somebody that's not sexually based. So that's the kissing, snuggling, cuddling, crush kind of attraction. And it's more about the attraction shifting from one to the other. And this needs to be very, very well explained, because obviously there's going to be less erections and there might be less spontaneous desire, but desire will still be in there within, just as it is within a feminizing setting. So decreased erections. Breast growth is always the most important thing for our trans women. It can take 3 to 6 months before the breast starts growing. It can take up to 4 years before you know what size breasts you're going to have. That's all genetically determined. And you can see the breasts are one of the very few things that are actually not reversible. Everything else will reverse. Definitely can have an effect on your fertility, but it's all not guaranteed. You can't use it as a contraception. It will decrease, obviously, the growing of beard and things like that. One can start having some effect on scalp hair. And unfortunately, the voice is the big challenge. So the male voice is due to a change in the voice box itself, and that's not reversible when you go onto estrogen. So quite often we refer them to speech therapists to help modulate the voice to be more feminine. So the medicines that we have, we've got estradiol as an injectable and as a patch. These are available in the private sector. And then the 2 oral preparations that we basically use, actually in our setting, we will only use Estrofem. Premarin is an option, but the Premarin also often requires also the anti-androgen remedies as well, but it's not as bioidentical as the Estrofem. So Estrofem is our referred choice. I'll show you how we do it in a minute. And then you have to add an anti-androgen because you're giving an oral one. And in our setting, it'll usually be spironolactone that you will use. So what this looks like. So you will start them on, for example, 2 milligrams of Estrofem a day, spironolactone 25 milligrams a day. Then you'll follow up 1 to 3 months, depending on the scenario of the patient, where you can then increase the Estrofem to 4 milligrams, spironolactone to 50. And by 6 months, they're usually on the maintenance dose they're going to be on that will create these changes. So it's usually about 6 milligrams of Estrofem and spironolactone 50 milligrams a day. Side effects we need to look at is headaches, just like contraception. Obviously, the increased risk of VTE, similar to contraception. There might be mood changes because they're going through puberty. And I've talked about those changes to the sexual response cycle and to libido. So in terms of monitoring bloods, because we're using spironolactone, we need to check the creatinine and potassium, as well as the ALT. And you're going to basically always do your potassium 4 weeks after adjusting the dose of your spironolactone. If available, which I don't think we have in the public sector, even in the public sector people don't always do, is that you can actually do estradiol levels. So what you do is on your lab form, you will write female, and then the lab form will give you the ranges for female estradiol levels, and that's your target if you want to work towards a target. More often though, Estrofem you will see in how the patient feels and experiences on it. And you don't actually want to go up with the dosing too quickly because then that puberty can be quite hectic. So mood changes, etc. So we do sort of a gradual approach. When we look at masculinizing gender affirming healthcare, so this promotes virilization. So oral testosterone, you can't give oral testosterone. It has to be IM or subcutaneous or through a patch. Some patients keep on bleeding, keep on having either spotting or periods, and then you can use something like Depo-Provera or Microval, the little mini pill, to actually suppress the period. So these are the changes. And again, you can see a lot of the changes are reversible. The thing that is not reversible is the growing of a beard, which is also usually the desirable effect for our trans men. That's what they want. So they like to grow a beard, and they can get male pattern balding depending on what their familial genetic scenario is. They can get increased muscle mass and strength. The period usually stops within 2 to 6 months, which may be reversible or not. They might get some clitoral hypertrophy, and there will be some vaginal atrophy, which usually is not noticeable. What does happen with the trans men, and this is also not reversible, is that the voice will deepen. So it actually does change the voice box, and that does not go back if they stop the treatment. So there's two preparations mainly. We don't have the patch. There's testosterone sapionate, or also called depot testosterone. That's the one we've got at the moment. And then there's testosterone arducanate, Nebido. We actually had that until last year, and they've recently changed them. Not very expensive. This is how you do it. This is a subcutaneous injection similar to our diabetics. So you start, it's 100 milligrams per ml. You give them like a 10 ml ampule. They start off with 0.5 ml subcutaneous per week. And then again, one can put it up by 0.1 ml at a time. And usually there's a dose of between 0.18 to 1 ml would end up being their sort of maintenance dose. You can either do it weekly, or it can be like 1 or 2 ml every 2 weeks. So the big side of the one that everybody complains about is the acne. So you're going through a male puberty, and testosterone classically connected to acne. So they might end up having patches of acne, which will eventually settle down. But what ends up happening is they have the same risks as a man of their age would have. So, you know, in the framing and risk score, we've got a different risk that we're using in terms of dyslipidemia. So they've got a high risk of dyslipidemia, more likely to get hypertension. And the only side effect that's particular is polycythemia. So we need to keep an eye on the HB, and they would need blood to give blood if they do develop polycythemias. So we do an HB and A1LT. You start 1 month, 3 months, 6 months, and then annually. And again, if possible, one can do the same and measure testosterone levels. So you put male on your NHLS form. Just got a last couple of sections where I want to talk specifically a little bit about the political landscape, because it's having an impact on our ability to roll out programs, like we've seen with the cancelling of the PEPFAR grants. And what we are seeing globally